Hello, everyone. This is Dr. Susan Hudson from Texas Fertility Center with another episode of Fertility Docs Uncensored. I am here with my amazing, talented, beautiful co-host, Dr. Carrie Bedient from Fertility Center of Las Vegas.
Hi.
And Dr. Abby Eblen from Nashville Fertility Center.
Hey, everybody.
How are you guys doing?
Doing
Good.
great.
Abby,
Good,
I
good.
want to hear about the dresses you saw last week.
So, one of the kind of cool things about being in our little niche, our little world in Nashville is that we kind of have every now and then you get sort of like a, behind the scenes kind of look at stuff. And so Dolly Parton, who's a big fave of everybody's and really by all accounts from every source I know of, and I know a few inside sources, everybody says she's such a wonderful person and she is, but, she had some connections, I think, with one of the people at our a local college, Lipscomb College here, Lipscomb University, actually. And so she had about 25 dresses that went on display in conjunction with a new book she put out. It's called Dolly Parton and the Makers and My Life in Rhinestones. And really, it really highlights more than her. It highlights the people that work for her. And
That's
so the
neat.
really kind of
That's cool.
fascinating thing about her is, obviously, in case you hadn't noticed, she doesn't really have quite the normal shape that every other woman has. And so she can't really buy things off the rack. And so she has like two dressmakers. Let's see, she has a designer. She has a person who for 20 years, all he's done is he coordinates her outfits. He designs some of her outfits. He coordinates, like if she's going to go, like if she has an appearance on Good Morning America, the Today Show, like three places that, like in New York, he coordinates her jewelry, her hats, her shoes, everything she's going to wear. And in a year's time, he said that the group of the five of them that work here locally that she employs, the dressmakers, the designers, the people that put rhinestones on, makes the jewelry for her, basically they have to make about 300 outfits for her a year for all the appearances that she has. And so
Wow.
it's just a full-time
Whoa.
operation. And so it was really fascinating to see these beautiful dresses. And she says, and they both say that all of them say the same thing. They say the gaudier it is, the more she likes it. And she's quoted somewhere, and I've heard this quote several times about, yeah, it takes a lot of money to look this cheap. And so she loves rhinestones and she's, doesn't apologize for it. She loves the flashier it is, the better. And
She
just
pulls
seeing
it
the
off
construct.
so great, though. I'm
She
like,
Oh, she
really
does.
does.
And she's just such a good person too. Like my kids, when they were born, got books every month for the first 5 years of their lives from the Dolly Parton Imagination Library. She put all this
Uh-huh.
money up so that every kid in the state of Tennessee would have a book. And so and we actually had somebody in our office that her husband was in Dolly Parton's band and still, I think, records and stuff with her. And so by all accounts, she's just the nicest person ever and just does so many good things for our state. So, but anyway, it was really fun to see her outfits and just how well designed and well cut they were, and just like, but all the different versions of what Dolly would wear, and the flashier the better. So it was really cool. It was really fun.
That's
that's neat.
awesome.
That's neat. I have to say, one of my favorite Christmas movies of all time is Smoky Mountain Christmas, which was like a made-for-TV Christmas movie with her and John Ritter and what was his name?
I don't know that I've ever seen that. I'm
He
gonna
was
have to
the
look
guy
that
who
up.
played the Fall Guy. Do you remember the Fall Guy back in like the day, like a long time ago? Whoever, I'm pretty sure it was that actor, and I'm sorry if anybody's listening and they know the name of this actor. I'm blanking on it this moment. But it's a
Smoky Mountain
great
Christmas.
Christmas movie. It just warms my heart. It's one of my favorites. So
Oh, I love
Oh,
second to
9 to
White
5.
Christmas.
yeah, 9 to 5. And the
9 to
interesting thing
5.
about Dolly too. Here's the other interesting thing. I'm about 5-ish, maybe 5.5 feet tall. She's 5 feet tall. She has this teeny tiny little waist, it looks like, and just, massively large breast, and I think it's so emphasized because she's such a tiny little person. I didn't realize she was only 5 feet tall. So
I remember hearing years ago she had lost some weight, and with her weight loss, like all other people, she had lost breast dimensions, and she
yeah.
literally burned her bras just because she was like, nobody's getting a hold of these.
Oh yeah. Oh yeah. I bet you that would go on, that'd go for a lot of money somewhere. That was a good idea.
All right, let's do a couple of questions. Our first one is, hi ladies, thank you for all you do. A little history. I had 2 biochemical pregnancies from 4 total IVF FET cycles. Embryos were PGT tested, no PCOS, adenomyosis, polyps, fibroids, or hormonal disorders. I'm 38 years old, FSH 9.1, LH 7.4, estradiol 38, AMH 1.26. Recently did 1 week of letrozole plus 2 Lupron shots in case I have silent endometriosis, but that wasn't successful. I have 1 more embryo. I'm passing up on the BCL6 test because it's time consuming so that I can do this transfer before I get older. So if I need to do another stem, I can before my reserve diminishes anymore. We are trying letrozole Lupron again, except this time letrozole is daily for 30 days and Lupron is also daily for 30 days. What is the chance this dosage change will be successful?
I mean, if you're making the assumption that, okay, we're going to skip the BCL6, we're going to go straight into the treatment for it. I think all the recommended treatment is closer to 2 months, potentially 3 months. I don't know that they've done any studies for 30 days. Now, a lot of that is just functionality of you, when you're doing a study like that to figure out, okay, what's the point where it works? You have to arbitrarily set time points. And so, 3 months, 2 months, 1 month, all of that. So I actually don't know that data off the top of my head. I kind of want to say that they did 30 days and found that 2 to 3 months was more effective, but you can't quote me on that because I don't know that.
Yeah, I know it's at least 2 months because by 1 month you're not even really down regulated, or you're just close to being down regulated after the first month. So if you're really trying to down regulate
Yeah.
endometriosis, you'd have to at least do it 2 months.
So I have a question. When you guys are doing this, I usually either use Orlissa or Depo Lupron, 1 shot, 1 month and then another shot another month. It sounds like she's doing daily small doses like we do in IVF. Do you think what's your thoughts on the impact of doing it daily versus doing Depo Lupron?
You're saying letrozole?
No,
the leuprolide.
she's taking
Oh,
low-dose Leuprolide on a daily basis versus a big dose once a month. Any thoughts?
No.
I think after 5 or 6 days you're down regulated anyway, so it probably doesn't matter. It just really be pits to take daily shots though, when you could do it for.
Did you guys know that Orlissa, which is the pill, pill way to downregulate, it's the only pill that we have because everything else is an injection. That the size of that molecule is tiny compared to like what we would see in an antagonist like ganirelix or cetrotide. And the affinity is like, oh God, this number is sitting on my desk and I don't have it in front of me. It's a phenomenally higher affinity. So that
like it attaches to the receptor and it's like shuts it down.
Exactly. And it stays attached forever. And because it's a much smaller molecule, you get proportionately more per dose than you do of like ganirelix or cetrotide. Like I'm watching that. There's something there. I don't know where the fire is yet, but I'm going to find it.
I don't have a ton of experience with Orlissa, but I know Susan, you do. Do you see, is it harder to get people, like if you've done Orlissa you just do it for a month, you said before
I do 2 months. I do 2 months in the
So do you see, is it hard to get their patient's lining stimulated? Because you're trying, on the one hand, you're down regulating for a couple months and then you want to up regulate them and thicken up their lining. You don't see that that's a problem at all? Good.
No,
okay.
I can't even think of somebody that I've had to extend it. And I have one person in mind who has historically had a thin lining. We were successful in getting her pregnant. We ended up doing Orlissa this time just because she has recurrent losses and current implantation failure. And we actually didn't even have to do anything above and beyond what we did before. So I haven't had any problems growing a lining.
That's interesting. Well, that's good to know because that's the one thing I would worry about with Orlissa, based on what Carrie's saying, is that you wouldn't be able to upregulate them.
No, because it clears out of your
We've done
system.
our own little study here.
It clears. I mean, that's kind of one of the beautiful things about Orlissa is if you're not tolerating it, you stop it, and within 2 or 3 days, it's out of your system.
Gotcha.
And so, even if you're doing it before you're going to do a stimulation, you really probably shouldn't have that much. You definitely shouldn't have any issues with the lining.
Yeah.
It shouldn't hit the lining because it's hitting pituitary receptors, not necessarily uterine receptors in the same way. Where it's a potential issue is with a trigger. Like if you're depending on LH to go up and you're doing a Lupron trigger with
I have done it before. I haven't done it often. It's a handful of times. I've done it a handful of times and haven't had problems with my Lupron trigger.
It can work. it doesn't always work.
Always work.
Yeah. So that's, I don't know. We'll
Might be
see.
one of those good dual trigger people.
Yeah.
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 All right. Okie doke. One more question. I've had 6 miscarriages in the last 2 years. In January 2023, I found I had chronic endometritis, got a round of antibiotics, got pregnant shortly after, but ended in miscarriage. A rebiopsy showed I was positive for CE, got on doxyflagyl amoxicillin, got pregnant again shortly thereafter. A chemical new biopsy showed I was still positive for CE.
Chronic endometritis.
Yes. Had a microbiota test showing
Mhm.
I had 94% bad and 1% good bacteria. Got on Augmentin and got my clear last week. Public healthcare here does not believe in chronic endometritis and claims my recurrent pregnancy loss are due to my age was between 37 to 39. I just turned 40 and am terrified I will keep on miscarrying even though my chronic endometritis is gone. What are the chances that my miscarriages are caused by my age rather than the chronic endometritis?
I mean, statistically, if you're 40, roughly the risk of miscarriage is about the same as your age because of the genetic impacts. I mean, we know there's other things that can cause miscarriage, but certainly, at 40, you have about a 40% chance, no matter what, of, miscarriage. I think chronic endometritis is not something that we routinely test for. I think there's a place for it for some patients. I worry that if I'm doing a biopsy, and you didn't really mention how they tested it, but if you're doing a biopsy and then you're culturing the tissue that you take from that biopsy, I worry that it's going to be contaminated as it goes through the vagina, because the vagina has lots and lots and lots of germs. And so, it's really hard to know for sure if you truly were one of those people that really had chronic endometritis. Certainly, it doesn't help anything. It's kind of like layers of an onion. It may contribute, and certainly now that it looks negative, that's great news. But I think it's one of those things. Nobody has a crystal ball, and it's there's no way for us to really know, what's going to happen with the outcome, just based on what we know about you.
Carrie?
Chronic endometritis is found in, I want to say like 15 to 18% of people. It's a little bit higher in chronic miscarriages. I would say treating it definitely makes sense. I don't have as much data about the microbiome assays and how that translates to clinical effect. But I know certainly we do a lot of hysteroscopies looking to clear endometritis before we ever do a transfer, particularly on people who haven't had good luck, who don't have very many embryos, all of those things. And so sometimes you can just go in and you can see like, oh, that's inflamed. And sometimes it's super obvious and ugly and awful. And sometimes it's a little bit more subtle and it's just these little tiny punctate erythematous red lesions that are in there. And so we treat and you go back a month later and it's all cleared. And so I don't think it will hurt to have it cleared. I do think because of your age, there's an inherent part of your age alone that is related to miscarriages. And even with all the fertility testing known to Dr. Kind, the book of things that have to happen in order to get to a live birth is like 4 to 5 inches thick. The book of things that we can test is like half-inch thick. And so there's a lot of gap in there between what we can test and what needs to actually happen. And so there's a decent chance that whatever is going on is in that gap. And so, yeah, treat all the things that you can, but there's a component of age that's a part of this that, and the unknown that we kind of got to do it anyway. And the only way to know is to try. And sometimes that's very painful in the trying.
Yeah. And an important thing to know also is recurrent pregnancy loss is one of those things that we know that at least 30% of people who have one identifiable factor are going to have more than one identifiable factor to contribute to recurrent pregnancy loss. So you're not unusual that there may be multiple things going on. It could be a contributing factor of your chronic endometritis, a contributing factor that of these 6 pregnancies that you've had, probably a reasonable number of those were chromosomally abnormal. And so making sure you really have had a complete recurrent pregnancy loss, make sure your thyroid is where it needs to be, make sure your prolactin is where it needs to be, that your chromosomes are normal, partner's chromosomes are normal, checked for acquired blood clotting conditions like antiphospholipid antibody syndrome. I think all of those are are important. And if you try again and you're not successful, then considering things like IVF with PGT testing or pre-implantation genetic testing, so that we know that we're putting back a chromosomally normal embryo. It doesn't guarantee, but it definitely takes out a huge factor in the equation. And it's the right thing for some people. It's not the right thing for others. And the best decision is the one that feels best to you.
The other thing for this particular patient is because she already had PGTA on these embryos, the question is what type of PGTA, because there's a couple different platforms, meaning the way that they run the tests. Not all of these platforms are created equal.
I don't think she's had PGTA.
No, I thought she did.
No.
Oh, did I hear that wrong? Okay.
Yeah, I think you're thinking of a different question. I think these are all spontaneous pregnancies.
Oh, I'm thinking of the question before. That's what I was thinking of.
Yeah.
Fine. See, I even took notes, but it was on the other part.
A lot of information.
It is a lot of information, but thank you for sharing with us. And I hope we're able to give you some good information to work with from here. So today, we are going to talk about fertility after 45. And though we know that this may not apply to everybody who's listening, I think we're going to share some really good information that you can take regardless of what your age is for the realities of what does fertility look like after 45. So let's start off with, does age matter and why?
Unfortunately, it does. And like we alluded to, and actually the question you just presented to us was a good lead into this. We know that as the eggs age in your body, it's harder and harder for them to wake up and divide correctly. So every month when your body gets that trigger to release the egg has to wake up after, we'll say in this case, 45 years. And a lot of times the egg has two sets of chromosomes that are together, and they have to divide perfectly down the middle. So if you remember back to high school biology, when a chromosome lines up in a straight line, there's these little hair cells that pull the chromosomes apart. And so chromosomes look like big X's. And so half have to go to one side, half have to go the other. If anything changes, if there's too few that go one direction or too many that go another direction, that means the genetics of that egg are going to be abnormal. Even in the best case scenario, we know that there's a 50-50 shot, even if you're 25, 50-50 chance. And when you release an egg, it's going to have the right number of chromosomes. As you get older, every year, the deck sort of gets stacked against you. And by 40, about 90% of the eggs are genetically abnormal that you release. Over 40, it's really challenging to even find one that's genetically normal. So, we all know people that have had healthy babies over the age of 40. But it's always a miraculous process, but it's really miraculous the older you get to release an egg that has the right number of chromosomes. So that's one of the biggest challenges as women age.
So if somebody is either in a new relationship or just now started trying because they've been on birth control or something like this up until this point in time, and they are, say, just saying happy birthday 45, what are their chances of getting pregnant on their own?
It's so low. I mean, it's so
I was trying to see what percentage you were going to say, Carrie, because I was listening hard. What percentage would you say? Really low.
I mean, when you look at, so there's a diagram, and I pull this out whenever I'm lecturing to the med students, to the residents, to everybody. And it is the single most horrifying graph that you can show to a set of young women, because what it is, it's two lines. And so it's looking at chance of pregnancy, and then it's got age, and it kind of compares the two. And the one line is, what is your chance of getting spontaneously pregnant? And as you hit over about 43, 44, it goes to essentially zero. And then the other one is, what is your likelihood of miscarriage? And as you hit 44, 45, it goes almost to 100%. And it is a horrifying graph. Like when I put it up, I apologize to whatever group of learners I'm doing. Like, I'm really sorry, guys. This is scarier than anything you're going to see at Halloween. And I can see the looks of recognition that go across their faces, because these are brilliant young women, and they look at it, and you can just see all of the 4-letter words crossing their mind. You can see the panic, because it's a really scary graph. And it doesn't mean that someone cannot, will not, will never be pregnant at those ages. It just means if you put 10,000 people in a stadium, it's maybe one. And so that's, all of us have learned, you never say never, you never say always, and you never say never, because
That's right.
all of us have had the universe just smack our hands of like, you do
Yeah.
not know everything, and multiple times throughout the course of your career. And so you never say always, you never say never, but just because it is possible does not mean that it is probable. And that is a huge, huge difference. And so when people come in and say, well, you're not saying it's never, so you're saying there's a chance. I mean, technically that's true, but
how do things change because sometimes we have these people who come in who haven't been trying at all. How does it change your perspective if they've been having not preventing intercourse for a year or two beforehand? Because I think those two groups of people come into us with a different psyche.
I think if, people don't realize that they're trying when they're really trying. So trying to me means you're having sex, a couple times a week, not preventing or not using any type of birth control. You're exposed to sperm and you're ovulating, you're having regular cycles. That is actually, that counts. You're trying to get pregnant, whether you really see it that way or not. So if somebody's not been using birth control for more than a year, that's the definition of infertility. If you're over 36, we say if you've tried for 6 times, 6 months, and you haven't gotten pregnant, you need to see a fertility doctor at that point. So I think people don't look at it the same way. They think, well, whether they're on birth control or they're not actually trying, meaning they're not monitoring their ovulation and all that, they think that it doesn't count, but it does.
absolutely, absolutely. And I think the psyche difference that happens is when people come in and they say, oh, well, I haven't been trying, whether you've been actively on birth control or just not preventing, I haven't been actively trying. And so if I actively try, a lot is going to change between when I was not actively trying and when I am. And unfortunately, that's not necessarily the case. And I see this a lot because my patient population is just disgustingly gorgeous and fit, and they are thoughtful and they take care of themselves, and they're like a doctor's dream of, oh no, there's no high blood pressure, there's no diabetes, there's no whatever. And it's certainly not everybody, but it's a decent proportion. And they come in and they say, and they look, not just say, they look. I had a 47-year-old who looked like she was, I kid you not, 28 years old. It was just incredible. And her ovaries are 47, 48 years old. And so all of those changes have still happened within the ovaries, despite how fit and beautiful and young appearing she is.
Yeah, the question I thought you were going to ask, Susan, and you didn't ask was, what's the difference between a 25-year-old that's trying to get pregnant for the first time and a 45-year-old that's trying to get pregnant the first time? So I'll throw that question at you.
Well, it's apples and oranges. It totally is, because we, like you've discussed, the quality and the quantity of the eggs that are available in somebody who is 45 plus is just so low that the chances of a natural conception are going to be very, very low. And whereas in somebody who's 27, there's probably about a 20 to 25% chance she's going to get pregnant that first month.
What are the other factors, though, that may be different between a 25 and a 45-year-old? This is a read my mind question.
This is totally
like medical issues or
right. As you age, you are going to be at increased risks of pregnancy complications, mainly because your vasculature has aged. Even if you look fantastic on the outside, your blood vessels have been pumping blood for 40 something years, and so you're going to have an increased risk of diabetes in pregnancy, high blood pressure issues in pregnancy, increased risk of C-section, increased risk of preterm delivery, and increased risk of complications of all those things. And so once we have somebody in our clinic, if you're going to deliver beyond the age of 45, we actually require you to get a cardiac evaluation. Yep. Because though it is rare, going through pregnancy, labor, and delivery is one of the most stressful things your heart is ever going to go through. And as much as we may want a baby, we want you more. And so we want to know that we don't have a baseline cardiac risk that we're concerned about. But even with a normal cardiac evaluation, it's important to know that you are higher risk than the other person. Now, that doesn't mean you can't carry a healthy pregnancy. Okay. But it means you're going to be watched closer and you are at an increased risk of all those complications. Now, oftentimes the two retorts that we get are, I have a family member, mom, grandma, auntie, whoever
Yes.
it is,
Had a baby when
or-
she was 50.
or we have famous person reference.
Mhm.
Okay.
Yes.
How do you respond? Those are two different responses, in my opinion. Okay.
Mhm.
But how do you respond to those two inquiries?
So starting with the famous person one, I always say, I am not their doctor, but I would bet a substantial amount of money. And this is from someone who, although I live next to the Las Vegas Strip,
Has never gambled.
I have never gambled. Like, I would spend a substantial amount of money on a bet that they either had frozen eggs from when they were younger or that they are using a donor egg. Because statistically, the likelihood of you having a baby at age 49, 50, 51 from your own eggs at those ages, and that you
Being
are an
famous.
international pop star, the likelihood is just so phenomenally low that, again, you never say never, you never say always, but I would put a substantial amount of money on the fact that that was not her egg from that age.
I concur. Abby, what about the family history?
Well, I do think there's some validity to the fact that, there are genetics involved, but we just don't know to what degree genetics are involved. I mean, like you said, Carrie, earlier, it's possible, but it's not probable. Now, egg freezing has not been around for all that long. So if you had a 45-year-old relative that got pregnant using her own eggs, it probably wasn't from frozen eggs anyway. It could still be from donor eggs. I mean, certainly they have their rights to privacy as well and may not share it with everybody. I mean, it's possible, but it's just not likely that it would happen. I mean, I think it's a miraculous process if it happens at 45 or 46 on their own without any fertility treatment.
So when we're looking at somebody who is, say, 45 to 55, at our clinic, we don't permit embryo transfers beyond the age of your 56th birthday. And I'm sure that varies from clinic to clinic.
Yeah.
But if you are in that decade, what ages do you feel comfortable with reassuring testing, actually pursuing pregnancy, trying with her own eggs?
Go ahead, Abby.
So I'm not sure what the question is. So you're asking
if you are between 45 and 55,
okay.
where along that continuum do you say, with reassuring testing, I think it's reasonable for us to give it a shot or start looking at other options?
I mean, we'll let people, if somebody really wants to try, my feeling is, do I think it's likely they're going to get pregnant using their eggs? I don't. But I think sometimes emotionally, I think we as women particularly, and maybe men too, sort of need some sort of like closure. And so I think everybody kind of wants to feel like they're the exception to the rule. And every now and then we do see an exception to the rule. So I don't think there's any harm in letting somebody try with fairly benign fertility treatments like oral medicine, insemination, maybe up until the age. I mean, I would probably go up to the age of 47, 48. I don't have a hard and fast rule. I know some clinics do. Just to let them try for a few months. And then if it doesn't work, then I'm like, I just don't think this is going to work. We need to move on to something that really is going to work if you truly want to be a parent. And that would be donor eggs or donor embryos usually.
What do you do, Carrie?
I counsel to high heaven. So when they first come in those age groups, we start off a conversation. I get their history and we explain physiology, and I start to say, look, just based on your age alone, this is without any of your specific data. These are the numbers. And typically after 45, it's well under 1%. And so I say, okay, let's say your testing is amazing. Let's say I triple your success rates. You're still not even talking about 3%, because we are so far under 1%. And so I say, I want you to keep that in mind. I am a firm believer in closure cycles because I think that has a role in it.
What do you
But
mean by closure cycle, Carrie?
meaning before someone goes to donor egg without having tried their own eggs in whatever capacity, um, feeling like they've had a chance, because I think that can make a really important difference in
Mhm.
someone's acceptance, not only now, but down the line of, yep, I had to use a donor egg to get my family. And so I think that can be important. And it's person dependent. Like that is not doctor dependent. That is do you need a closure cycle or not? Some people come in knowing, oh, these rates are awful. This is expensive. This is involved. I'm not going to screw around with the stuff that's not going to work. So it's very patient dependent. But I think closure cycles are potentially important. But when I do them, it's counseling at the very first visit. It's counseling at their follow-up visit. I usually have the coordinator talking with them, going over it as well, because I am absolutely fine with you being disappointed when it didn't work, even if you were 45 and we said, hey, the results of this are not likely to be good. Disappointment, I 100% understand. I don't want surprise,
Absolutely.
because when we can see this coming from a mile away, just because of statistics and biology, like if you decide to do this, that's okay, but I need you to know what you're deciding to do. And that's why we counsel to high heaven, because it's not necessarily wrong to try, especially when you're in that 45, 46 range where you may feel like you need to, but beyond that, it's, I don't want to do futile treatment either, because that's not only not good for you, that's not good for me, and that's not good for my staff either. Like,
Mhm.
there's other human beings involved in this too, that we're trying to balance everybody doing the right thing, and that's hard.
Right. So if we try something and we're not successful, or we decide as a team, meaning patient, physician, that we're wanting to look at other options, the main two other options are things like donor egg and donor embryo. And we have episodes talking about those specifically, but can we talk kind of at a high level what options are available when we're looking at donor egg and donor embryo?
Yeah.
So donor egg would be basically where you say, well, if my egg is not going to work, biologically, it can't be my genetics, but I want my partner to use sperm. So you can use partner sperm, put it with an egg and create an embryo, and then you can carry the pregnancy. And so I always tell my patients, even though biologically the child is not related to you, you're an integral part of this. If it weren't for your uterus and, you're home away from home for 9 months, the baby wouldn't be here. And so the advantage, I think, for a lot of women is you get to experience pregnancy, you get to carry a pregnancy. Once the baby's born, you can breastfeed the baby. Generally, in this day and age, though, we tend to really counsel toward, making sure that everybody's aware of the situation. There's really no anonymity, as we've talked about before, with genetic materials now, with things like Ancestry.com and 23andMe. So ahead of time, you'll talk to a counselor. They'll talk about the implications and kind of ways that you may want to tell your child about their origin, basically. But overall, I think it's a really good process and a really good thing that a lot of people can do. And you want to have a baby, you don't want to just stop, or a lot of people don't want to just stop. They want to have a baby, and this is the best way to do it if you're in that age group.
Carrie, what were you going to add?
I was going to add that they've done studies, because I pulled this paper for one of my patients she was about 36 when she came to me, and she ended up having to use donor egg because she was an ovarian failure at a young age. And the paper showed that the woman who carries the pregnancy, there is an exchange of genetic material. And so it's
Oh,
not,
and what do you mean by exchange of genetic material?
I mean, it's not as though, like, let's say you use a donor egg to conceive your children. And you're, blonde haired, blue eyed. And your donor is
Not.
dark hair, dark, yeah, like not just dark featured. There's not going to be all of a sudden you're popping out a blue eyed kid. What it's talking about is epigenetic changes. So the way the genes are turned off and on has an influence. There's even the article is starting to talk about some of the things, like you can even find little bits of DNA because of the exchange many years later. And so it's not as though it is an inherent structural, functional part, but it's still present.
There is an impact that your body and your genetics can play on your baby.
Yes. Yes.
That's
And
beautiful.
it's the same as the difference of if you are smoking versus not smoking in your pregnancy, that will have an impact.
Obesity, not obese.
Obesity, not obese, you versus your neighbor carrying your pregnancy. Like there's potential for differences.
Interesting. Very cool.
Carrie, can you talk a little bit about donor embryo?
So donor embryo is when you are accepting an embryo that was created by another couple, and the other couple has decided for whatever reason that they are no longer using those embryos, either because they have the established family size they want, they've decided no longer to pursue treatment, whatever it may be, and any reason you can think of is one that we have heard for this. And they've decided that they are going to give their embryos up for another couple to use. So with donor embryo, on the one hand, it's fantastic because those embryos are made. All of the drama that goes into making them, a lot of the expense that goes into making them, that is all done and ready to go. They are already in a vial, cryopreserved, ready for implantation, transfer to your uterus. The flip side of this is that all of the control that you potentially can exert when you're using an egg donor or a sperm donor is gone. In the sense that you can choose an egg donor who has your hair color, eye color, general height, ethnic background, also happens to love peanut butter Oreos or whatever. Like you can choose all of that. It may take a while to find, but you can theoretically choose all of that. With a donated embryo, what you see is what you get, because it's whatever the characteristics of that couple are is what they are. And you can't necessarily say, well, I have these characteristics, my partner has these characteristics, and so we have to find a donating couple that has those. You're not going to find a match. You might if you're lucky. Like it's not like they're non-existent, but it's a hell of a lot harder than if you're looking for a specific donor who is very similar to you. And so having those expectations set appropriately is important. The other thing that's important is the age of the woman when she gave those eggs, and the sperm status, quality status of the man providing the sperm for those embryos. Those make a big deal. With a donor egg, typically your donor is, 31, 32, 33 or younger and has correspondingly fantastic success rates. With a donated embryo, it is entirely possible that the woman giving the egg for that embryo was 41 years old. And even if it's PGT tested, you are going to have lower success rates because of the impact of a 41-year-old egg. And so all of those things are important to know, along with the number of embryos that you get. Some people are going to donate one embryo, some people are going to have 8, and everything in between. And so it just depends on whatever the characteristics are of that specific lot of embryos as to what your chances are down the line.
So one thing I'd like to tell our listeners, if you're thinking about something like donor eggs or donor embryos, sometimes people feel like they're the only people in the world that are facing this. And this is actually a problem that lots of women or couples face. I always say I never go up to somebody who has a baby and go like, oh, it looks just like you, unless I was intimately involved in the creation of that pregnancy, because I have seen so many people make the choices to go to either donor egg or donor embryo, and not necessarily people you would expect to make those choices. Mm-hmm. And so it's a beautiful gift if it's one you wish to pursue. It's a great option. And it's the right thing for some people and not the right thing for others. But, just like I said, we want to provide you the information you need to figure out what's the best way to grow your family if you wish to do that.
Mm-hmm. And if you do decide to use donor egg, donor embryo, whatever, and you're really worried about, oh crap, my child may not look like me at all, just keep in mind there's a lot of genetic variability. Like there are a lot of people, when you look at their children, you can look at one member of a sibling pair and go, oh, they look like a good blend between both parents. And you can look at the other one and go, there is absolutely no resemblance between that child and one of the parents. And that doesn't necessarily have anything to do with just anything beyond genetic variability. So it wasn't donor, wasn't anything. I mean, you look at my kids, it is very clearly I didn't contribute to my son at all. I popped him out. I know that egg was mine, but he is a duplicate of my husband. And so whereas my daughter is a split between the two of us. And so, there's variation here, no matter how well or nonchalantly you choose, it will be what it will be.
It's funny, over the years that I've done this, my donor egg coordinator and I have joked about how amazingly similar babies look more. A lot of our donor egg babies look more like their mom than they do their dad, because they're so specific in kind of the characteristics. And I've had plenty of patients go, yeah, it's uncanny. People be like, oh, she looks just like you, or he looks just like you, because the characteristics have matched so well. So I think that's always a cool thing.
I think one of my big learning experiences actually happened when I was a medical student. I will remember this day forever. I was working with a general surgeon, and very sweet man, and he did lots of thyroid surgeries and cholecystectomies, and just a great teacher. And he had a picture of his son on his desk. And this was many, many years ago. And I remember this like it was yesterday. Like, this was about 20 years ago. And I was like, oh my goodness, he looks just like you. He goes, I know. Funny thing is, though, he's adopted.
Oh, wow.
And so it was one of those moments in my life that I was like, wow, like there's a big plan here. There is.
Yeah.
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 Yeah. I have a patient where I walked into like some kid's birthday party, and I saw one of the dads that I had several years before, and dad and mom looked dramatically different from each other. And I knew that they'd used a donor egg, because she came in saying, look, I'm 41, my egg testing's crap. I'm not going to mess around. Just take me straight to donor egg. And I looked at their daughter and I'm like, oh my God, there's no resemblance to dad at all. It is 100% mom. And I am 100% sure that is not her egg, because I know the donor gave it. Like, it's incredible.
It's very cool. It's very cool how it works out. It does. Yep. Very good. Well, I think we covered a lot of important information today. And to our audience, thank you so much for listening. Be sure to listen next week for more. Be sure to subscribe and leave us a review in Apple Podcasts. Would love to hear from you. We are also on Instagram, Facebook, and YouTube. So follow us, subscribe, and stay updated on all things fertility.
You can also visit us on fertility.suncensored.com to submit questions. All questions will be answered on our Ask the Doc segment. So be sure and leave us episode ideas. We'd love to hear from you.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right. Have a wonderful day. We'll talk to you soon.
Bye.
Bye.
Bye.